Hi, welcome, good morning. It is, what day is it? May 14th, it's Thursday, House Healthcare. So we have, um, I believe, past third reading. It's on its sort of day in between where things go from Senate and House, and we need to hear on how the Senate amended 611. If you remember, this was sort of the DEVA technical housekeeping bill. I think you were the reporter of this bill. So, Jen, you want to come up and walk us through the changes?
You need your seat.
Yes, it's awful. I'll never join that again.
Good morning, Jen Carvey, Office of Legislative Counsel. So I have prepared, and I think you have in front of you and on the page, a version of H611 as it passed the House, showing markup from the Senate proposal of amendment. So you see in context, there's not a strike all, it's just some instances of amendment. Now put it up on the screen.
I can't remember who reported this. I can't remember. Yeah, yay.
Okay, so this is an act relating to miscellaneous provisions affecting the Department of Vermont Health Access. And this, so all of the changes, as I said, should be in highlighted in yellow. So they made no changes in section 1, which was the prescription drug cost transparency reports, and taking Department of Vermont Health Access out of the requirement to report on certain drugs for which its costs have gone up. That information was not particularly relevant given the federal pricing and federal pricing constraints, or information constraints around the pricing for prescription drugs and Medicaid. Section 2, as it came out of this committee, was amending some language enacted last year in Act 55 around 340B covered entities and their contract pharmacies. And what you were doing in that section was repealing a provision that requires the manufacturers to make the funding reductions available through a discount and not a rebate. And there was some concern about that's a part of litigation that is ongoing, and there's some concern about whether federal law will ultimately allow that or not. So that is still being repealed, but there was a request in the Senate, and I think you're going to hear from Bi-State afterward. So Mary Kate can explain more about the specifics, but there's language in the existing statute that prohibits a manufacturer or its agent from directly or indirectly requiring a 340B covered entity to submit various types of data as a condition for allowing acquisition of the 340B drug by or delivery of the drug to, and what's in statute now is to a 340B contract pharmacy, unless the claims or utilization data sharing is required by the federal government. And since enactment of this legislation last year, as I understand it, some of this issue has now shifted to the manufacturers requiring this of the 340B covered entities themselves. So the legislation had only addressed the contract pharmacies. That's where the issue lay at the time. This would add or a 340B covered entity. And I'll let Mary Kate explain to you more about what that looks like in practice and why they proposed that language. All right, the next changes don't occur for a while, so they made no changes to the Medicaid and Exchange Advisory Committee section, the Reflective Health Benefits Plan section, that's section 4, no changes to section 5 on the Clinical Utilization Review Board, no changes in section 6 on the calculation of income for VFARM, no changes to 7 on the increase to the prepaid burial arrangements for Medicaid eligibility. Our next change comes in section 9. So in section 8, sections 8 and 9 now both deal with the doula state plan amendment for the doula Medicaid coverage and operationalizing that Medicaid coverage for doulas. And so if you remember in your bill, you amended last year's Act 50, delaying the date from July of 2026 to July of 2027, when DEVA has to seek a state plan amendment. It was pointed out in the Senate that actually this language so that was in section 7. Section 8, I think also you delayed the effective date until 2027. It was pointed out in the Senate that the language around the certification program and rulemaking should also be July 1st, 2027, not July 1st, 2028. So everything working on the same timeline. And it sounds like, as I understand from DIVA and others, they're still working through with OPR what that certification program would need to look like for them, for Medicaid to be comfortable covering it. So this pushes back the certification program at OPR until July 1st, 2027, but still requiring OPR to start rulemaking before that to make sure the rules are in place on that date. All right, and then finally, we have a new section, almost finally, the effective date changes later. Because it's a new section that was not in the bill that you sent over. And this is around,
I'm sorry, can I ask you a question?
yes,
Because I'm just trying to think through here and I'm trying to remember history. Didn't we keep it 26 because we wanted them to at least be able to have the certification? I mean, even though Medicaid wouldn't be able to cover it, didn't we still want them to be able to certify doulas so you could become a certified doula?
well, the purpose for the voluntary certification is to be eligible to receive Medicaid payments. And my understanding is that the certification program is not ready yet, is what I recall
Okay.
testimony. So,
All right.
so I think given the delay of the timing and the Medicaid coverage delay until the later of July 1st, 2027, or approval of the state's plan, which now doesn't need to be requested until July 1st, 2027, everything, I think there was appreciation for the breathing space to figure out the. I don't think anybody's here who can testify more specifically on that.
Trying
For
to
you.
professionalize. I didn't know if we're delaying.
Yes, but it's still only for these community-based perinatal doulas, which is a subset of doulas, and has no effect on their doula's ability to operate
Okay.
before and after.
Wendy.
So I'm just trying to recall here, they're certified. They've never been certified.
Right, there's no,
Okay,
there's no regulation of doulas currently.
That was it.
And in order for Medicaid to provide coverage, there needed to be a certification or some form of regulation. OPR recommended certification as the most appropriate, and which is sort of the middle level. But they are still working out, I think, between DIVA and OPR, what DIVA will require or what they believe the federal government will require in order to allow Medicaid.
Thank you.
Thanks. Sorry, I lost.
Seems like a million years ago.
Section 10 is a new section, as I mentioned. This is relating to HIV prevention medications. And this would add some language into an insurance statute, 8 VSA 4077, which is more broadly on reproductive health care services. And it adds definitions of HIV prevention drug, meaning any pre-exposure prophylaxis drug or post-exposure prophylaxis drug, including oral and long-acting injectable formulations that is approved by the FDA for HIV prevention or is otherwise authorized for HIV prevention pursuant to FDA labeling or federal clinical guidelines. And I think you're going to hear more from from later witnesses about why this language. And then there's a definition added of supportive health service. And that is any health service that is necessary to monitor a patient to ensure the safe and effective ongoing use of an HIV prevention drug, and includes an office visit, lab testing, testing for sexually transmitted infection, medication self-management and adherence counseling, patient education and counseling by the patient's healthcare provider regarding the appropriate use of the HIV prevention drug and any other health services that are components of comprehensive HIV prevention drug services as determined by the patient's healthcare provider. Those are our definitions. And then subdivision 2 here requires a health insurance plan to provide coverage for HIV pre-exposure prophylaxis drugs, often referred to as PrEP, the pre-exposure prophylaxis PrEP, as recommended by the U.S. Preventive Services Task Force as of a date certain, in this case, August 22nd, 2023. And it requires this coverage to be provided without any deductible, co-insurance, co-payment, or other cost-sharing requirement, except to the extent that coverage would disqualify a high deductible plan from eligibility for a health savings account under federal law. I'm going to pause here for a second to say this coverage already exists. This is already required under federal law. To my knowledge, payers are complying with this. So this would be putting into state law what is already required. And that is because PrEP, this pre-exposure prophylaxis drug, is considered it has an A recommendation from the U.S. Preventive Services Task Force, and all A and B rated medications are required to be covered without cost sharing under federal law, under the Affordable Care Act. And we have put similar language into Vermont statute as well. But I think there are some concerns that there may be changes to U.S. Preventive Services Task Force recommendations and or coverage requirements under the federal law if there are changes there. And so this would kind of keep that status quo for the pre-exposure prophylaxis drugs. The post-exposure PEP drugs are do not have an rating by the U.S. Preventive Services Task Force, although I believe some aspect of them are currently covered by many of the plans.
This is unrelated, but is birth control rated by the U.S. Preventive Service Task Force? Is it an A or B?
I don't know where it is preventive. I don't know if it's addressed in the U.S. Preventive Services Task Force.
Just wondering
Had
why
coverage requirements.
we as a state had to make it with local insurance or copay.
So largely, our state law was tracking federal law, but with certain expansions beyond what was required under federal law. So that's the health insurance piece. And then Medicaid is also addressed in this section. And this requires Medicaid and any other public health care assistance program offered or administered by the state or a subdivision or instrumentality of the state, except for any program that is funded in whole or in part by federal grants that have prohibitions on coverage of HIV prevention drugs. Any other than a program like that, Medicaid must provide coverage of HIV prevention drugs. So in that case, we're talking about both PrEP and PEP, pre-exposure and post-exposure prophylaxis medications, and supportive health services, that was that definition, and shall not require any cost sharing, including co-payments, provide coverage without requiring prior authorization or any other protocol that may restrict or delay dispensing for at least one FDA-approved drug in each category of pre-exposure and post-exposure prophylaxis drugs, and not deny coverage based on the type of healthcare professional issuing the prescription for any HIV prevention drug for which Medicaid does not require prior authorization, as long as the healthcare professional is acting within their authorized scope of practice and they're enrolled as a participating provider in Vermont Medicaid. This last piece is looking in part at some language in another bill, which is the OPR bill, H588, which as amended in the Senate would allow pharmacists to prescribe pre and post-exposure prophylaxis medications for HIV prevention. So this is recognizing that there may be pharmacists prescribing these medications in the future, and so would prohibit Medicaid from denying coverage on that. And then finally, in the effective date section, it had been July 1st, 2026. There were some sections that people wanted to have take effect on passage. Then it became clear there wasn't really anything in the bill that needed to wait until July 1st. So instead of carving some out, we just moved the whole thing to passage.
Okay.
And I will note on the section 10, the reproductive health care services, the addition of the HIV prevention language was the result of some protracted negotiations between various stakeholders. So I think this is ultimately consensus language among DIVA, Blue Cross Blue Shield, at least, DFR, and the advocates for HIV prevention. So hard fought and one language.
But essentially, we're codifying what's already.
You are codifying some existing practice, yes, and addressing, to address concerns that current practice could change if other factors change.
Just a clarification for me, if I may. On page 13, health insurance plan, that's on 2. Who is that?
This is in our, so this is in our health insurance statute, so this is major medical insurance plans. So all the plans
We talk about
that cover-
QHP,
QHP is large group market, yeah, commercial,
everybody.
commercial market that we regulate.
Okay. Any other questions for Jen on? Thank you, Jen.
Thank you. Sorry. I was just curious about in C, the language about that, which Medicaid does not require prior authorization. What does that mean? Yeah,
So
how does that
that's
apply?
tying back to B. On the previous page, so Medicaid is required to provide coverage for HIV prevention drugs, and if you go to B,
Mhm.
provide coverage without requiring prior authorization for at least one FDA-approved drug in each of the PrEP and PEP categories.
Mhm.
So then when you go to C, not deny coverage based on the type of professional for each of those drugs. So at least one drug in each category, whichever ones they are not requiring prior authorization for. So it could be.
Okay, so,
More than that,
okay,
but-
so there's a list of drugs that do not require prior authorization,
under-
and that would be appropriate.
So under B,
Yeah,
DIVA will have to provide coverage without requiring prior authorization for at least one drug in each category. So
Right.
figure minimum 2 drugs without prior authorization. And then on C, not deny coverage because a pharmacist issued a drug, a prescription for one of those drugs that Medicaid.
as
put
long as they're
there.
on the list,
Yeah.
that they're fine.
Right, as long as they're on the
Did not require-
no prior authorization list, which could be more than, that it just gives DIVA the control over their
Flexibility
formulary.
of What
Yeah.
they're doing, yeah, okay. Thank you.
Thanks, Jen.
Contraception is on DA.
What's that?
Contraception is considered.
Oh, you're looking, I'm looking at it too, I
That's
got.
all right.
Same
No,
with tobacco
well,
sensation. Polygraph supplements.
I was just trying to
I
figure
know,
out
I
why
never-
we had to do a state.
Again, there were concerns that there could be some changes
Mhm.
at the federal level that would affect what was required to be covered at the state level.
The former member from Barry's like all-time favorite thing that. Okay, Mary Kate, want to come on up?
Do you need me to, sorry, Mary Kate Molman, Bi-State Primary Care, for the record. Do you need me, would you like me to put this section on the screen or you can just follow along?
What section?
It's just section 2,
The 340B.
yeah, five little words.
Don't need to go.
340B covered entity.
Yes.
Yeah, no need to put it up.
Okay, so quick little background, as quickly as I can do around a very complex program. This committee last year really led the charge in passing some really important legislation for fairly qualified health centers, which was the Act 50, what became Act 55. In that bill, provided some really good protections for the 340B around specific to the contract pharmacies, meaning that manufacturers, well, let's start back. Manufacturers starting around 2020 started imposing a lot of requirements of covered entities and their contract pharmacies to participate in the 340B program. The 340B program, just to give a little bit of help to give a little background on that, refresh people's memories. Okay.
You said, I'll give you a brief. I'm brief.
I'm gonna do my best. All right, so Medicare and for manufacturers to participate in Medicaid and Medicare, which are fairly big books of business, they have to participate in the 340B program. The 340B program requires that manufacturers provide their prescription drugs to what we call covered entities, which are generally safety net providers, FQHCs, critical access hospitals, Ryan White clinics, Planned Parenthood. And the idea is they provide these drugs at a discounted price. And then when these prescription drugs are prescribed, these clinics get reimbursed at the full typical reimbursement rate. And that delta, that difference, that savings from not having to spend the full price to purchase the drugs, they can use that money to support other healthcare services and to support their patients. FQHCs are required by federal law to use this savings to benefit their patients. They can provide free dental care, reduced pharmaceutical prices for those qualifying, can support like Medicare patients who can't afford their copays. So there's really a way to help support and reduce barriers to access to care for patients, for FQHCs. So that is what we're trying to preserve. The steps by manufacturers have since eroded how much those savings that FQHCs can receive. This bill that you guys passed last year was very helpful in restoring some of those savings. This is a critical piece of financial stability for our FQHCs. And at the time, the manufacturers were really focused on putting these requirements on the contract pharmacies, these reporting requirements. Since then, we've had at least 3 manufacturers explicitly start targeting in-house pharmacies. So for Notch, their in-house pharmacy now has to do a lot of these reportings to continue to participate and benefit from the 340B program. These 5 little words that we asked the Senate to include, and they did, would expand not just protections for the contract pharmacies, but for the in-house pharmacies, for covered entities.
Crystal clear.
What else is it?
There's not.
There are FQ2HCs, and then who else does this apply to?
All other covered entities within
Who are all other covered entities such as like critical access hospital?
critical. I believe most of our hospitals, or if all of our hospitals qualify to participate in 340B.
Okay, so all hospitals, FQHCs, that would be it?
Those are the primary ones in the state. Planned Parenthood.
Okay.
Don't know if we have any Ryan White clinics.
Not familiar with that.
Those are the clinics specific for people with HIV.
Okay, so last year, we said that the manufacturer cannot require the contract pharmacy to give them all of this information.
Mhm.
So instead, they've pivoted to, then we'll just ask the covered entity.
Mhm.
Okay, and we're saying, no, you can't do that either.
Exactly.
Yeah, it shall not.
Is there anybody else we should include, just so we
Well,
don't come
maybe
back
because
next year?
I believe this covers. Yeah.
It covers it all.
Yeah.
Okay.
That's not new language that in B, it says its agent shall not direct, that's already in law.
Yep.
Yes.
It's just expanding it to the covered entity itself and the in-house pharmacy.
That was from Act
Because we could just
55.
put it in as contract pharmacy.
Yeah, that was in Act 55,
Yep.
which I'm looking at, but
Yep.
it's too much to process at this moment.
All right. Well, thank you.
That's it. Thank you.
Thank you. I should ask, did you have any thoughts or feelings around, does Bi-State? I know you provide services to tens of thousands of Vermonters. Do you have any thoughts on the section The whole section at the end that was added.
HIV section.
We have no objections.
Thank you.
Because that's mostly an insurance section, right? I mean, it's not,
Insurance and medical.
yeah, and so it has nothing really to do with prescribing or
It may affect access,
coverage, but
right, but I mean, it may affect access to service.
We have next Laura Byrne. And as Laura comes on, let me just reach over Blue Cross Blue Shield. I don't see you on our agenda, but do you want to speak to this section as well?
I think it's very quickly, Courtney Harness, Blue Cross and Blue Shield of Vermont. Now?
No, hold on. Let's not do it. Let's find out what's there and what problems are solved, and let's talk with Ms. Byrne. Hi, welcome.
Hi, thank you for hearing my testimony. I'm Laura Byrne, the Executive Director of the HIV/HCV Resource Center, and I'm speaking on behalf of our organization as well as AIDS Project of Southern Vermont and Vermont Cares. And I would like to talk about PrEP and PEP. A brief review. HIV pre-exposure prophylaxis, PrEP, is a highly effective evidence-based HIV prevention medication. When taken consistently, it reduces the risk of HIV acquisition from sex by approximately 99% and meaningfully lowers associated risk associated with injection drug use as well. Despite its proven effectiveness, PrEP remains significantly underutilized in Vermont, and recent federal actions threaten access to this critical HIV prevention tool. HIV post-exposure prophylaxis, PEP, may be prescribed to those who, in the last 72 hours, may have been exposed to HIV during sex, may have had an occupational exposure or shared needles, or have been sexually assaulted. State action is urgent. Access to HIV prevention medications, including PrEP and PEP, is a proven public health strategy that also delivers significant cost savings. Preventing one HIV infection can save the healthcare system approximately $554,000 in lifetime medical expense. In June 2025, the U.S. Supreme Court's decision in Kennedy versus Braidwood gave the Secretary of Health and Human Services authority to reject preventative care recommendations, putting the future of PrEP coverage at risk. Federal guidance currently prohibits prior authorization for PrEP, but these protections can be reversed by a new administration. Vermont cannot rely on unstable federal policy to protect access to life-saving HIV prevention. Barriers such as cost sharing, prior authorization, and limited prescribing access continue to delay or prevent care for people at risk of HIV. As federal policy governing access to life-saving HIV prevention has remained unstable, Vermont must establish its own legislative authority to ensure that access to PrEP and PEP is as broad, reliable, and barrier-free as possible. So we're just asking it, PrEP and PEP are already being paid for now by federal law, but we're concerned that that could change, and we're just asking that Vermont create its own legislative authority. Thank you.
And you worked on this language with various stakeholders?
Yes, with our with Gail Zatz and with the other directors of the Vermont AIDS service organizations, Melissa Farr and Samba Diallo.
Any questions for Laura? All right. Well, thank you. Thank you so
Thank
much
you.
for explaining that to us.
Thank you.
Blue Cross Blue Shield, you want to just?
Sure. Thank you. Courtney Harness, Blue Cross and Blue Shield of Vermont. Good morning. I did literally less than a minute ago just send something to Tasha for you all. It was a letter that was requested by the Senate Health and Welfare Committee just stating our coverage for these drugs. And I would just reiterate what Jen Carby said, which is we did have the opportunity to come together as a group and work on this language. We believe that it does codify what our current actually a little less than what our current coverage is, but does codify our prep coverage almost spot on. And we're perfectly happy with this language and happy to cover above and beyond what federal law requires.
Great,
Thank you.
Yeah,
thank you.
yeah.
Would the healthcare advocate like to, would the healthcare
I
advocate?
can just spend a minute to say hello, good morning, Mike Fisher. That the HCA also participated in a bunch of complicated conversations with other advocates and with DFR and DIVA. Are pleased with the language that the Senate passed. And I think that it advances the charge of us making these really important preventative medications available to them.
Thank you. Great, so are there any questions around this? Do we want to, do we have Brian with us today? Oh. I'm sorry, can I? Do we do a straw poll? Just a straw poll? Okay,
Yeah, because the bill has not been referred.
okay. Are there anyone have any questions or concerns about what the Senate did? Any clarifications? No?
No.
Okay. Okay. Well, I guess I would ask that all in favor of concurring with the Senate proposal of amendment on page 611. All those in favor signify by 2, 3, 5, 6, 7, 8.
I'm in favor of it.
Okay. 10, 1, 10, 0, 1. 10, 0, 1. Great. Well, thank you. We're gonna go into 8:16, but we gotta wait for Katie. And she won't be here until 10 o'clock. So let's take a break until 10 o'clock.